At AMSA SRH, we aim to be the primary platform for students who want to work towards dismantling these taboos and addressing reproductive health issues locally and worldwide. We believe firmly in the right of every individual to have access to the tools necessary to have a safe and reproductive health journey throughout their lives. Join us today as we explore the pressing issue of heavy menstrual bleeding, a condition that is chronically under-recognized, underdiagnosed, and undertreated. We could not have organised this event without the tireless support of Bleed Better, who are at the forefront of advocacy for patients with HMB, dedicated to supporting their patient journeys and raising awareness for this critical health issue. We'd like to especially thank Dr. Talat, the founder of Bleed Better, for all her expertise and support throughout this process. Without further ado, I'll hand over to Dr. Talat, who will speak to you a little bit more about herself and her passion for menstrual health.
Thank you so much, Dravin. And I'd like to start by thanking what a wonderful team of medical students in AMSA consists of, and how, you are the future of health. And it is such a privilege to speak to you today. And I'm grateful that you've taken out of your Friday evening to amplify this very important cause. So Bleed Better is actually a charity, and it was honestly not that I remotely ever thought that I would be embarking on this journey of advocacy to this degree. But it has stemmed from an unmet clinical need and from the indignation of, I would be so indignant at the end of the week thinking, how are we not meeting the core needs of women with heavy menstrual bleeding? Why are women that I'm seeing presenting for care so late, and why are they putting up with it, and why are they using words like it's only 2 days, or it's only 1 day, or it's just 3 days? So women are constantly trivializing their menstrual loss, which is clearly excessive. I can see that they're iron deficient, or they're having a lost quality of life. So it was from that space that I reflected, and basically our whole team said, you know what, it actually doesn't have a campaign. Now think of all the campaigns that which is so important. Honestly, I don't mean to be petty, and it's not a competition, but think of everything that that has a month, a week. And heavy menstrual bleeding affects a quarter of reproductive age women. So let that sink in. That's 1 in 4 women. And these are women in our schools. They are at our work. They are in our community. They are at every forum that you can think of. And they are half of them haven't seen a healthcare provider. So the statistics, sadly, haven't really shifted over the years. Quarter have HMB. Half haven't seen a doctor or a healthcare provider. 2/3 are iron deficient. And so this is a very major public health issue. And then we thought, okay, fine, we are going to start that International Heavy Menstrual Bleeding Day. And here we are today as part of that bigger picture advocacy for women with heavy periods. And I think that it is really focusing not only on society to say, hang on, what is the clarity between an abnormal and a normal period? But it's also bringing the message that, you know what, there's so much support for you. Medical, surgical, and radiological options, there's absolutely no reason for someone to put up with it. And I'd like to end by saying that the words Bleed Better were very carefully chosen, because we had quite a few options to go through. And I thought, again, our biggest teachers are the community that we serve. And I would think that many women would start their consult with me saying, I don't want hormones, or I don't want this, or I'm worried about this, or I checked this online. And we would start the discussion with what the complication of surgery could be, or what the side effect of a hormonal option, for example, could be. And that's why I thought, as clinicians, we need to acknowledge that maybe the solutions are not perfect. And that's why we want to encourage you to bleed better. And I thought that that would sort of acknowledge the person's concern, but also say, hang on, your baseline at the moment seems pretty ordinary, and you're telling me you're not functioning with your activities of daily living. Let's bring the focus on your quality of life, and let's move you together to the type of quality of life that you deserve. Thank you.
Thank you so much, Dr. Tullett, for that introduction. I think that perfectly summarized the importance of having this event today and the importance of educating our future clinicians on why this issue is so incredibly important. With that, we would now begin introducing our panelists today. Can we start with Dr. Megan, please?
Sorry, I just needed to unmute myself. Hi. Thank you so much for having me here. So my name's Megan Young. I'm a GP with an interest in women's health, and I also was privileged to participate in International Heavy Menstrual Bleeding Day. Yeah, so lovely to be talking to you.
Thank you so much for that. Can you please have Dr. Dean?
Yes, hello, my name's Dean Conrad. I'm an obstetrician and gynecologist based in Southeast Sydney. I did have a slide to show of some embarrassing photos, so maybe they've maybe censored them. Oh, there they are. So I'm a former UNSW student, and I was also an AMSA member back in the day, and I found a photo of myself from 2006 at one of the AMSA convention parties, dressed in nice fluoro gear and a tie bucket night party. So yeah, something to share some embarrassing moments. I'm currently a staff specialist at the Southern Hospital, and I work with a lot of students as a lecturer there. And I thought I'd share a photo of some behind the scenes of one of our conveners putting on a pregnant suit and pretending to be a pregnant patient, showing, hey, we are having fun while you're doing the exam, so don't stress out, it's all good. And I'm also a training supervisor for an AGES training program. AGES is the Australian Gynae Endoscopy and Surgery Society. And the reason why I'm here today is I think that the passion that I have is represented by the big photo on the right there. I focus on laparoscopic and robotic or minimally invasive surgical techniques to remove very large uterine masses. So for patients who are really struggling with their bleeding and despite therapies are not able to bleed better or a hysterectomy is required, using these techniques to keep the keyhole incisions, these patients get back on their feet, back into their life, minimal time off work, away from their families in the hospital. And it's hard work for the team, but we've got good photos of the team holding long specimens where we've taken a long time to cut them into long strips so we can keep the patient feeling good. And it's real satisfying to see patients doing so well. So that's a bit about me and why I'm here.
Thank you so much, Dr. Dean, for sharing all those moments with us. Can we now get Dr. Anastasia to introduce herself?
Thank you so much. So I am not as cool as Dean. So my name is Anastasia Keegan. I'm a women's health haematologist, and I'm head of Department of Haematology at a women's and newborns hospital based in Perth, Western Australia. And I'm also a transfusion medicine specialist with expertise in patient blood management. And I'm the current president of the Australian and New Zealand Society of Blood Transfusion. So I am slightly out of the loop when you think about how we can help women bleed better. And when women experience heavy menstrual bleeding, my role is really to help think about a systems approach to women who have abnormal bleeding, because we estimate about 15 to 20% of women with heavy menstrual bleeding actually have an undiagnosed bleeding disorder. So I'm here to say, don't just forget about something that's really obvious, think about a systems approach and could this person have an undiagnosed bleeding disorder? So that's how I link up with the team.
Thank you so much for that, Dr. Anastasia. And now can we have Sophia, please?
Yes, hello and good evening, everybody. My name is Sophia Guinness, and I'm a third-year postgrad medical student at Macquarie University in Sydney. I'm originally from Toronto, Canada, and I hold a master's degree in global health from McMaster University, which is in Canada. So during my postgraduate studies, I developed a deep passion for global women's health, both from a clinical perspective, but also through the lens of advocacy. And I came to appreciate how cultural norms and health system limitations can shape inequities that many women face in accessing care. And earlier this year, I had the privilege of completing my gynecology placement with Dr. Talat Uppal, who's here tonight and we've already heard from. And I was incredibly inspired by the intentional and holistic approach that her practice takes in managing abnormal uterine bleeding. So since then, I've joined Bleed Better as a volunteer to continue this work in a meaningful way. It's a real honor to be here tonight to contribute to this dialogue that not only elevates awareness around heavy menstrual bleeding, but also drives us towards better, more inclusive care for women everywhere. And you'll be hearing more from me later about what I learned on placement and as well as a global public health reflection about women's health.
Thank you so much, Sophia, for that amazing introduction. Can we please have Dr. Tullett introduce herself now?
Thank you, Vienna. So yes, so I'm a gynecologist, obstetrician and gynecologist, but I'm predominantly doing far more gynecology now. And honestly, this HMB journey started as a passion, but now it's bordering on an obsession. And basically only because, again, like I said, it affects a quarter of women. And I think that I felt that it genuinely, and I still haven't understood why, but often appeared to me like it's an orphan of medicine, or it's a like almost like a less prioritized area of women's health. And so I am very privileged to have done some ultrasound training in the past, and it's almost like all the dots connected for me in terms of I have an interest in management and in health services and in thinking almost big picture, apart from obviously meeting the needs of the patients through our practice, but stepping back and thinking, right, what can we do to serve the community or to look at this even as an international issue? So, and honestly, in my mind, when we started Bleed Better, is a woman that we are never going to meet. She's on a farm somewhere. She has children. She will lead a better life because of what we do. So it is much more than, obviously I have a medical center, but it is much more than an interest from that angle. It is actually a cause. And so I feel that I am very supportive and respectful of the excellent work that is done in primary care. And so we ended up setting up an abnormal uterine bleeding hub, which is the first of its kind in Australia, in that we do end-to-end care of women with abnormal bleeding. And we are accredited by RACGP. And because I wanted to try and nail that integration between primary and secondary care, we know that healthcare, sadly, in Australia sometimes is very siloed. So we're trying to break those barriers. And actually, as healthcare providers, we should be looking through the lens of the patient as she journeys from different points in her care. So we try to bring that as the focus rather than the funding model or, basically which clinician can do what scope of practice. Rather, we said, okay, here's a multidisciplinary team who can bring what to this woman's journey. What point is the gap still left? How can we close the gap for her care? And one thing that I leveraged on is I wanted to share is around digital health. Now my children and our wonderful reception and admin team and practice management team probably smile when I say I work in digital health, because they're like, she can't even turn the computer on and off. But the reality is that it has given us opportunity to create impact. So I think digital health is women's health and women's health is digital health. We shouldn't be dividing the two. And so that has allowed us to try and look at the journey as a pathway, and then to say, look, how can we leverage technology, whether it's an AI scribe, whether it is how does the ultrasound report the report and get into interoperability into the patient journey, whether it is, the use of various technologies to make her actual medical care better. How can we leverage on these? And remember, we're coming on a background of women being not necessarily included in research. Even the rats and the mice in lab were not female many times until recently. So I think it's just so wonderful to look at heavy menstrual bleeding as an issue that we're all trying to collectively support, but also to say, you know what, we're creating a pathway for women with women, and it's something that really hopefully will change the way that care is delivered for this very common medical condition. Thank you.
Thank you so much, Dr. Tullett, for that incredibly detailed introduction. And lastly, could we have Paula introduce herself?
Thanks so much, Vienna. Hi, everyone. I'm Paula Bradbrook. Thank you so much for giving up your Friday evening to come along and dedicate yourselves to really understanding this condition. I'm participating this evening, sharing my lived experience as a heavy menstrual bleeder for over 3 decades. I have over 25 years corporate leadership experience, and I've really dedicated my career to fostering change, driving strategic impacts, but also mentoring women in the workplace. And my personal journey with also heavy menstrual bleeding, but also a surgical menopause, really inspired me to transition my skills across to become really dedicated in championing women's health education and equality. So I'm the founder of Your Menopause Doula, so I support women with the gap between clinical care and understanding their perimenopause and menopause symptoms, and the full body, mind, spirit experience. And I'm also co-founder of Her Health Hero, which is a initiative empowering young women and communities with really vital health education that we should be getting much earlier on in life than being surprised later on that some of these issues and challenges can be resolved for us, and we don't have to fight every day to feel well. Thank you.
Thank you so much, Paula, for that introduction. And I hope with all of those introductions, everyone was able to get a better idea of who our panelists are and what they're going to be bringing to the conversation today. And with that, we'd actually like to take the opportunity to bring all of you through a patient journey and for our panelists to show you how a patient interaction may look like in this space, and then for us to learn from it. Please take it away, panelists.
Thank you. So after starting my period at 15 and having a very different experience to a lot of my friends, not that we really spoke about it, but there was a lot of noticeable differences. I felt that my period lasted a lot longer. The first couple of days were a lot heavier. My little period sanitary pack that I had wasn't so little. It was quite large compared to everyone else's little pack that seemed to be able to get them through the day. And after having a conversation a number of times with both my mum and Nana, was told, well, you know, you're a heavy set girl. A lot of your friends are more petite. Sometimes it takes a while for your hormones to sort of settle down. So I just accepted it and waited. 2 children later, working full time, you know, been back and forth to doctors and raised different concerns, but really didn't have any of those needs met. And now today, after the birth of my second child, and I am still just finishing up breastfeeding, and I've returned to work and he's 4 months old, my periods have really come back quite strong and heavy and feel even more uncontrollable. So I am going to sit down and talk to Dr. Megan today.
Yeah, so Paula, yeah, so your periods have recently come back after having your baby. So how long have they been back for now?
Yeah, they came back around the 3-month mark, and probably just as I'd started to wean him over to the bottle a little bit more.
Yeah. And is he fully weaned now?
He sometimes just has comfort feeds at night. I've returned to work full time. My husband's the full-time stay-at-home dad. So yes, I'm not getting much sleep because I feel guilty, you know, mum guilt. Working all day, I want to be able to provide him with some comfort in the evenings.
You must be exhausted.
I am so exhausted. I can't even remember what happened during the day when I get home in the evening. It's just a battle, a constant struggle.
And tell me a bit about what your periods have been doing since I've come back.
Yeah, I've always felt like I've had longer periods, and that I had to change a lot, you know, quite often, and you know, up in the middle of the night. I just feel like now it's really extreme, given I've got 2 children to manage, I'm working full time, and I just don't know. I've had lots of different options provided. None of them have suited me in the past. I find it challenging and quite expensive every time I go and have a conversation, and I'm really looking at how I can just solve this issue.
Yeah, fair enough. Yeah. Are you on any contraception at the moment?
I'm not. I actually really struggle with the synthetic pill, and I'm not. No, we're using other contraception, and given that my periods are 10 days and so much, that intimacy is definitely the last thing on my mind.
Yeah, no, that's fair enough. Yeah. And aside from the contraceptive pill, have you used any other hormonal methods previously?
No.
Yeah. And what were your periods like what was your cycle like before falling pregnant?
My cycle was around the 9-day mark, so sort of 28 days, and 9 days of those I was bleeding. I have been monitoring the last 2 months, and I do feel like that they're going for an extra day, and I do feel that they're so much heavier on day 1 and 2 as well.
Yeah. On those heavy days, how often are you needing to change tampons or pads?
It can be anywhere sort of every 40 minutes or so. I use the largest tampons available, and then I also, sometimes have to continue using maternity pads as well.
Yeah, that must be really difficult. And how are things overnight? Are you often having to wake overnight to change?
Yes, and there's been a couple of times where, it's been the middle of the night, I'm half asleep, and, the next morning my husband has commented that, am I okay? I've kind of left a little bit of a crime scene behind in the bathroom, which is just, terrible.
Yeah. How were and did you have any difficulty falling pregnant?
No, I was actually, both my children were surprises, so very, little gifts.
Yes, yeah. And do you get much pain with your periods?
Yes, the pain it feels heavy. I do sometimes comment that kind of feels like my uterus is going to fall out of my vagina on some occasions, and my lower back pain is quite severe as well. So I use a lot of heat pads and take a lot of naprogesics, which obviously, I don't really like doing, but it gets me through. I have to work and I've got children to manage.
Yeah. And did you have you ever been told that you've had iron deficiency or anemia?
Yes, I've actually had 3 iron infusions previously, and I've only ever been told, well, it's, your periods might be a little heavy, and it's like trying to fill up a bucket with holes in it. So it's probably going to be your experience that you're just going to have to deal with and have regular checkups.
And with the birth of your 2 babies, were they vaginal or cesarean?
So my first one was vaginal and my second one was a cesarean.
Yeah. What was the reason for the cesarean?
He was 10 pound 11 and got stuck, so it was an emergency cesarean.
Yeah. And did you have much blood loss with either of the births?
No, not that they told me of. With my daughter, it didn't seem like that. With my son, I was pretty out of it, and nobody sort of stated afterwards how anything went, and I didn't ask, to be honest. I think I was just in shock.
Yeah. And do you think you would like to have any more children?
I would like to leave the door open at this point. Never say never, but I just want to get this resolved. I've got 2 beautiful children, a wonderful husband, a great job. I just want to be able to feel normal, and talking to people, I don't think this is very normal.
Yeah. It's not, and you certainly don't need to put up with it.
Thank you.
And have you ever taken anything other than the naprogesic? Have you ever, which is I think it's a good thing to take when you've got your period, because obviously it can help somewhat with the pain, and but it also can help a little bit with the reducing the bleeding. Have you ever taken anything? Have you ever taken anything for to reduce the amount? Anything else to reduce the amount of bleeding, like something called tranexamic acid or cyclocapron?
No, I've never been offered or heard about that before.
Yeah. So I think, we definitely need to do some further investigations to see what's going on with this, with this heavy bleeding, whether there's any underlying causes, and and obviously get you some treatment for it. But something that can be helpful in the short term is a tablet called tranexamic acid, and
Okay.
you take it. It's not hormonal, so it
Okay,
doesn't have
great.
any. Yeah. So it doesn't have any hormonal side effects. And you just take it on the heavy days of bleeding. You take 2 tablets 3 times a day. And it's safe safe for pretty much most women. You take it and it just reduces the amount that you're bleeding. So it's not going to be the whole solution, but it is going to be part of the solution. It might just help reduce the amount of bleeding that you're getting, just to make it a bit more manageable on those heavy days,
That
until
would
we
be
figure out what's going
amazing.
on.
Yeah, look, I think I'd really love to try that because I feel like I'm being held back at work. There's travel
course.
that I'm really nervous when I have to travel, and I know that that's the week that I've got my period, or it's earlier on when my period starts. So, oh gosh, if there's something I could do to try, absolutely, I would love that.
Yeah. And we until we we get some further investigation. We'll get some further investigations,
Mm.
and then. So I'm very worried about the amount. If you're changing tampons, up to every 40 minutes, I'm very worried about the amount of bleeding that you're having. So I think we need to do some investigations. We really need to see, are you anemic? So, that's is your body making enough of the part of the red blood cells that carry the oxygen around your body, that's that could be contributing to the fatigue that you're having. Are you iron deficient? We really need to figure out what's going on there, and we also need to do an ultrasound of your uterus, and so we do that on a particular time of your cycle, so between day 5 and 10 of your cycle. So if day 1 is the first day of your period, we do it between day 5 and 10, and that's going to give us the most level of information. Yeah.
Okay,
Does
thank
that all make
you.
sense? That's
Yeah,
okay.
it does.
That's okay.
Thank you. Thank you for
Yeah.
really listening to me. I appreciate that.
That's okay. And now I am going to get my colleague, Dr. Talat. Yeah.
Thanks so much, Dr. Megan.
Thank you.
Thank you so much, Megan and Paula. It's a delight to see you. And I understand that you've been bleeding for such a long time, ever since you started your periods. And this is a condition called heavy menstrual bleeding. Heavy menstrual bleeding is a quality of life based diagnosis. So basically, Paula, for anyone, if there has been a compromise in quality of life, whether it's your physical well-being, which it clearly has, whether it's an emotional or psychological context, because no one's going to feel their personal best when you're bleeding that heavily, and it can deteriorate, or whether it's a social context, as you know, many women are not able to then attend things or with their family or other.
I've missed out on so many events, and even when I'm there, I can't even enjoy them because I'm so
you're not
worried.
fully present.
No, not at all.
Yeah, and that is so I'd like to acknowledge that loss of quality of life. And the fourth angle, Paula, you've mentioned earlier about your job, how you're struggling during that as well. So a material context of quality of life loss is important to us as clinicians. So for example, like your younger self, if you couldn't get to school or you couldn't go swimming, or in this in your current situation where it's an issue of being purely focused at work. These are all different angles that could reflect either from the heavy menstrual bleeding itself, or from the iron deficiency, or from the anxiety that it can create or worsen. Okay, so like Dr. Megan made an excellent plan of trying to investigate what is going on. In general, when we look at abnormal bleeding, Paula, there are two main causes of abnormal bleeding. And this has been defined by an organization called FIGO, which is the Global Body for Gynecology. And what they've done is they've sort of called it palm coin. So whether it is because of the uterus, and at the uterine level, we might have a polyp in the uterus, we might have a fibroid, particularly the ones that poke into the uterus, or if they're multiple, or if they're really large. So polyp, which is like a chandelier in the uterus, usually benign, but not always. Polyp, fibroid, there's a condition called adenomyosis, in which the lining of the uterus is actually found in the muscle. And this can also make, give us those symptoms of heavy bleeding and or pain. And you clearly have both. And then the last one, which is not that common, thankfully, is actually uterine cancer. It's called endometrial cancer. And if we look at lifetime risk, it's 1 in 44 women. But it is so important to make sure, Paula, that we're not missing a cancer or a pre-cancer. Yeah, so that's the reason for the ultrasound. And basically, in terms of the non-structural causes, I'm going to lean on Anastasia, our wonderful hematologist, to give us a little bit more detail. But definitely, there can be non-structural causes that can create, this sort of symptom profile. And the main messages are that, we want to correct. I normally say to patients, there are 3 goals. We want to find answers. And mind you, Paula, half the time when we go looking, we actually can't, your ultrasound is normal, your blood results, except obviously for the iron deficiency and anemia, which are a consequence. But I'm talking in a causal context. Many times we don't find answers, about 50% of the time. That does not mean that you don't have a medical condition, which is HMB, but it just means that we don't have a definitive cause that we could pinpoint at this point. So we want to, number 1 goal, we want to find answers. Number 2, we want to do the medical plumbing, as I fondly call it. We want to reduce or stop the bleeding with you. And then we want to, number 3 is we want to replace losses. So we want to, your body has been struggling to keep pace with the amount of bleeding that you're having. And that iron deficiency is a really unkind space for women, and anemia particularly so. And on that note, Paula, initially we used to think iron deficiency, is a life trajectory issue. Women are iron deficient, then they fall pregnant, then they become more iron deficient. If we don't look proactively, they might have a bleed during their baby's delivery. And so it's like almost like a this really negative cycle they're on. But now the data is showing that actually iron deficiency anemia is a intergenerational issue. So this is why heavy menstrual bleeding is so important to put brakes on this condition, so that we're not only exposing you to a poor quality of life, but for an expectant mom, it's a gift that you give the unborn child in terms of consequences around neurological development, around birth weight of the baby, the well-being of the baby. So there are lots of consequences on our next generation as well through the iron deficiency in IDA. So back to your plan. The good part, Paula, is that this is a condition with so many solutions. And so that means that you can help guide us as to which one you feel is the best fit. And we want to hear from you in terms of if you have any preferences or anything you've read about that you're worried about. But ideally, I think of it as a pyramid. And the tranexamic acid was the base of that pyramid with non-steroidals. Tranexamic acid at the next level above that is hormonal, which could be pills, which could be injections, which could be, for example, a levonorgestrel IUD, which is known as a Mirena. Now, amongst all of those options, the Mirena in a Cochrane review has been shown to be the most effective option. Okay, and so basically it leads to above 90% of volume reduction at the 6-month mark, but it can create a lot of irregular spotting or irregular bleeding. It's not very clever at making 28-day 5 sort of cycles, but it's really good at reducing the bleeding. So again, Paula, if you felt this was a good fit option for you because you're not quite decided about whether you want a further baby or not, we've got to respect that, and we've got to support you to remain in the driving seat of your fertility making decision. I think that could be something you could consider, a hormonal angle. And above that, obviously, if your ultrasound shows a fibroid that is the type that we can I do a lot of, my interest is actually operative hysteroscopy. So I love taking out fibroids, polyps, making sure the woman doesn't have cancer, as I fondly call the lawn mowing. And so I kind of reduce that. I'm looking for any weeds, i.e., precancer, any polyps, any fibroids that are, submucosal, as we call them. So I would like to, if we fit into any of those benefits, I'd like to offer you that. Otherwise, I'm going to hand you over to my wonderful colleagues to tell us more.
Thank you.
Is it me up next? Okay, good. So, hey, Paula, thank you so much for sharing your story.
No worries. Thanks, Dr. Dean.
No problems. My name's Dean. I'm a minimally invasive pelvic surgeon, and my role will mainly be talking to you about hysterectomy. Tell me, what's your understanding of a hysterectomy? What does that word mean to you?
It means that I won't be able to have any more children. Maybe it could impact my hormones. Yeah, I'm really not sure. I'd love to hear more though, please.
Yeah, they're really good comments. So a hysterectomy is a way to 100% definitively treat your bleeding. It's the only treatment we have that I can guarantee your bleeding will stop. It's why I like it so much as a treatment option, because my patients are the happiest, and I do like having happy patients. It makes me feel good as a doctor. But it is a word that's quite scary and has some connotations to it. Having children is an important thing to know if it's right for you anymore. Because once you have a hysterectomy, it does involve removing the uterus, which means you will not be able to carry a pregnancy anymore. Importantly, we keep your ovaries. If we removed your ovaries as a part of this procedure, we would shorten your life expectancy. That takes the hormones away from your body, which are very important for your bone health and your cardiovascular health. And if we take them out, studies show shorten your life expectancy. And by preserving them, we maximize the hormones your body is getting and have ideally no effect on the ongoing production of hormones. There is some risks that the ovaries can get slightly damaged at the time, but generally that means that your menopause may come on about a year earlier or so. So if it was going to happen at 52, it might happen at 51. That's what we like to kind of aim for. You will still have your ovaries. So if you decided you wanted to have kids, you have eggs. So you could always do IVF and get eggs and find someone to carry the pregnancy for you. That's incredibly difficult in Australia. We only do benevolent surrogates here, and finding someone to do that is extremely difficult. So I'd very much, be trying to be as confident as possible that you've completed your family.
Of course.
If you are sure about that, then we can talk more detail about hysterectomy and what that involves. And through my interest is doing this through a minimally invasive process. So it doesn't really matter how big your uterus is, as long as it's big enough that we can fit into a specialized bag, and I'll explain what that means, then we can do your procedure through minimally invasive incisions. So usually it's small incisions, 5 to 8 millimeters in size, and four of them usually is enough. What happens is you have one night in hospital, the next morning you're walking around, generally minimal time off work, but there is still a recovery period of 2 to 3 weeks of taking time off work and doing minimal activity. Between 3 and 6 weeks you can do a little bit more, but still at the 6-week mark is still the amount of time you need to have a full recovery. So it does involve some time off and the risks involved with that.
Sure.
Importantly, we also take your cervix as a part of that procedure. Some people like to retain their cervix, but we found that really has no real benefit for patients. If you keep your cervix, the thought was that maybe it'll improve sexual function, but that's not really shown to be the case in a lot of the data. And if we keep your cervix, it means you still need to have pap smears, which is annoying. It also still means you might have some endometrial cells present, which can bleed. So we recommend to take out your cervix completely as a part of that. So that's called a total hysterectomy. The other thing we mentioned is keeping your ovaries, which is very important. But we don't like ovarian cancer for obvious reasons. And if we take out your tubes at the same time, actually 50% of ovarian cancers start in the tubes. So by doing so, we can reduce your risk of ovarian cancer by 50% without taking out your ovaries. And then we reduce the risk of uterine and cervical cancer by essentially 100%. Nothing in life is 100%, but as a way to minimize ongoing risks there. And one of the things that's really important I find as a part of a hysterectomy is that to date, we know that what you're going through is not, first of all, is not normal. I think it's really important to know that what you're experiencing is not normal. We shouldn't
Thank
normalize
you.
the experience that you're getting. At the moment, your diagnosis is heavy menstrual bleeding, but I can say with nearly 100% certainty you have something called adenomyosis, which Talat referred to beforehand. It refers to a condition that's related to endometriosis, where the lining of the uterus grows in the muscle. So each cycle when you're bleeding into your uterus, causing swelling. Classically, you get pain. Classically, you get backache and leg ache. Classically, you can get pain with sex. You don't always have troubles falling pregnant, which you didn't have, which is great. But all the symptoms you're experiencing are very, very likely of that. Also, you mentioned that, talking to people doesn't feel normal. Most people not most people, but a lot of people don't talk about it. And some people, they do talk about it. They talk about it with their mums. And the problem is a genetic condition. So you speak to your mum and they say, oh, it's normal to have heavy periods. And then you normalize that. And it's important to know it's a genetic cause. So if your children, you mentioned 2 children that you have, if they are women, it's important to know that they have this risk of developing adenomyosis. And so having a frank chat to them when the time comes for them to have their period, and identifying early that they may have a not normal experience like you had, and starting early, I think is important. And the other classic thing about adenomyosis, it worsens with each pregnancy. Something about how the uterus grows and shrinks, it doesn't do it very well, especially with cesarean sections. Whereas endometriosis tends to get better, adenomyosis tends to get worse. So we know they're similar, but they're not the same. Hysterectomy can 100% cure adenomyosis, and it's also the only way to diagnose it. Unfortunately, despite all the good techniques we've got for imaging, the only way we can know if you've got adenomyosis is take out your uterus, chop it in half, look at it in the microscope, and tell if you've got it. There's lots of good ways to know otherwise, but they're not as accurate. So I can pretty much guarantee you've got adenomyosis, and a hysterectomy is a cure for that and can diagnose it. And finally, if you've got endometriosis, we can look at that at the same time as hysterectomy. And you did mention that you felt quite heavy with your periods. You may also have an element of prolapse as a result of your vaginal birth. These can be addressed at the time of hysterectomy as well. A hysterectomy alone does slightly increase your risk of post-hysterectomy prolapse, but identifying that and treating that concurrently can minimize and improve that risk for you moving forward. So I think that's probably enough ranting from me. Did you have any questions or anything you wanted to ask
ranting.
me about?
Thank you. No, thank you so much. That was so much information and it really resonated with me. And I'm really grateful that you were able to explain this in such an easy way to understand, but also validate my symptoms and concerns and the impacts in my lifestyle. So I really appreciate that. Thank you. I will have to discuss with my husband, obviously, if we're going to have any more children or not. Child or dog? I'm probably leaning dog way.
Furry babies are good too.
Yes, they are. Thank you. Thank you so much, Dr. Dean. I'll definitely get back to you with my decision.
No problem. So I think I'll hand you over to our resident expert hematologist, I believe, who will tell us about, if you would want to avoid a hysterectomy, ways in which we can maybe manage you medically better.
Right. Thank you.
Hello, Paula. How are you going?
I'm good. Hi, Dr. Anastasia.
You must feel like your head is absolutely spinning.
It is a lot of information, but I feel really validated. I feel like I've got a really great team around me who have given me all the information I need to make a really great decision. So I'm really excited to talk to you to understand what options I also have available.
Fantastic. So I think my role I think my role as a women's health hematologist is I'm really involved in an entire woman's journey. So from the time when they first might start to get their period, all the way through to the time when they have a birth, and maybe in the postpartum and the perimenopausal period as well. And so one of the things that I always think about, if a woman has seen a gynecologist and have had some surgical options or oral treatment options for heavy menstrual bleeding, if there's something that doesn't make sense, so if they're needing multiple agents to control that heavy bleeding, it kind of sometimes can trigger thoughts of, oh, can there be a problem other than just heavy menstrual bleeding? And so what I wanted to talk to you today is just do some screening questions to say, could there be an underlying bleeding disorder that hasn't been picked up prior to now? And I know that Dr. Dean is quite confident based on your history and examination that we might get some good surgical answers here. But I think if we explore for underlying bleeding disorders, that can impact your life past the perimenopausal stage and into the future, but also your children. I think you mentioned you had a younger daughter, and if I can help you empower and screen for things for her, I think that would be a really important, because bleeding disorders are usually congenital. So when I think of bleeding disorders, I think of either congenital bleeding disorders, something that you're born with, or something that we do as healthcare providers. So we give you medications that can make you have a bleeding disorder. Can I check, are you on any regular medications other than maybe starting that tranexamic acid that Dr. Megan talked about?
No, just the tranexamic acid and some naprogesics every month, yeah.
And so the naprogesic will make your platelets a little bit less sticky, so might increase bleeding just a little bit. But I'd be really interested to know if you've ever suffered with, would you describe yourself, apart from the heavy menstrual bleeder thing, would you have said that you're a bleeder? Would you have said, gee, I bruise easily? Do you get problems with nosebleeds?
Yeah, well, actually, when I was younger, I had lots of nosebleeds. Yeah, and they lasted quite a long time. Yes.
And was that really in childhood? Because nosebleeds in childhood can be quite common.
Oh, yeah, it was. It was mainly in childhood. Yeah, I grew out of it. Yeah.
Yes. And what about easy bruising? Do you notice bruises pop up on your arms or your chest or your legs, or do they pop up where you haven't run into things, or you really just need to bump yourself to get some bruises?
No, I really need to bump myself to get bruises.
Okay, fantastic. And what about if you have a minor cut or a wound? So say you're emptying the dishwasher and you cut yourself on a knife or a glass that's broken. Do you think that blood would bleed more than 5 or 10 minutes?
No, not at all.
Any dental surgeries? Any teeth out?
Yes, I had my wisdom teeth out.
Okay, and tell me about that experience.
Wasn't great, but it healed pretty quickly, and there wasn't too much excess bleeding.
And so you need to go back to have, they didn't give you any treatment, or they needed to go back to do stitches or
No.
surgical? Wonderful. And now I'm going to ask you some extra strange questions. Have you ever noticed any blood in the urine when outside your menstrual cycle?
No.
Have you ever noticed any blood in your stools when you open your bowels?
No.
Excellent. And have you had any surgery in the past other than your cesarean section?
No.
Okay. And you mentioned before from a birthing experience, it wasn't a part of your journey that you really knew that you had significant blood loss at the time of birth?
No, I don't know if that was the case or not.
Okay, and these are the two last strange questions that I always ask. Never had any bleeding into joints, so your knees or your elbows or your hands?
No.
And have you ever had any bleeding on the brain or to the central nervous system?
No.
Terrifying questions, I am sorry.
Okay.
So those are the sort of questions I would explore. And so you've given us a really beautiful story of how heavy menstrual bleeding has impacted your life. And I can't go past that bleeding is absolutely abnormal, but you didn't have any other systems or any other areas of your body where you experienced abnormal bleeding. So I would say, just through the initial part of this screening called a bleeding assessment tool, these questions can help identify 70% of people who have an underlying genetic bleeding disorder. So it's a nice screen for primary practice, and it's something for you to keep in your mind when your daughter is getting a little bit older, thinking, has she got bleeding from areas outside, from multiple areas of bleeding? And if you did have some of those areas of abnormalities in bleeding in other sites, we'd think about doing some screening blood tests. But I think the most important things were the investigations that you had done with Dr. Megan, which was your full blood count and your iron studies. Did you have any extra questions or concerns about about a potential additional bleeding disorder other than for why you came to see me as a hematologist, rather than just do you feel comfortable to proceed with the gynecological?
I think I do. I think I don't feel like it's any other symptoms. I think you really sort of clarified that and asked the right questions, and I'm pretty confident that Dr. Dean's assessment is probably correct.
Wonderful. Well, I'm here if you need me. You're a phone call away now. It's because we've met each other, and if you've got any concerns, feel free to reach out.
Amazing. Thank you, Dr. Anastasia.
Paula.
All righty. So we're switching gears to hear from a med student perspective. So sorry to pause the play. It's so entertaining to watch this all fold out. What an incredible evening it's been so far. I'm so grateful for everyone's participation. I'm sure I speak on behalf of all the other med students listening tonight that I'm learning so much, and I'm sure everybody else is too. So I recently completed my gynecology placement at Women's Health Road with Dr. Talat, and I'd like to share some of what I learned, not just clinically, but also socially and systemically about heavy menstrual bleeding, or HMB. So at Women's Health Road, I immediately noticed that HMB isn't treated as just a period problem. It's taken very seriously, as it should be. The clinic is structured as a dedicated hub, similar to how we manage other chronic conditions, and it brings together a beautiful multidisciplinary team: specialist gynecology, general practice, pelvic floor physio, psychiatry, social work, to offer centralized, coordinated wraparound care. And this holistic setup means that care is not just about stopping the bleeding, but it's about understanding the physical, psychological, and social impacts and responding in real time. And what stood out to me most was how compassion is embedded into every step. Women are listened to, believed, and offered same-day diagnostics, including blood tests and ultrasounds and outpatient procedures like IUD insertions. And for these insertions, pain relief like Penthrox is readily available and offered to every patient. And procedures are done in a calming environment, sometimes even with recorded heart music playing in the background. And these small details send a big message that women's pain matters and menstrual health deserves dignity and care. But stepping back, what struck me just as much was how rarely this level of care exists globally. So despite the fact that 1 in 4 women of reproductive age experience HMB, we rarely talk about it, not in public, and frankly, not enough in medical school either. In my own experience, HMB barely gets a mention in our preclinical curriculum. And when it does, it's often taught purely through a biomedical lens, without much context of how disabling it can be, or the implications of its complications like iron deficiency anemia on women's well-being. And this silence mirrors a broader cultural and public health issue. According to the 2024 scoping review called Forbidden Conversations from Springer Nature Journal, menstrual health is still cloaked in taboo across many societies around the world, especially marginalized communities or those that are culturally and linguistically diverse, as well as low socioeconomic communities. On top of this, young people are rarely given accurate, comprehensive information about periods, let alone taught what's normal or when to seek help. And this lack of education paired with stigma and period poverty means that a lot of people suffer in silence, believing their discomfort is just something to push through and unaware of or don't know how to access the solutions that exist. And for some context, period poverty is when people can't afford menstrual products or time off work, and it affects 500 million women globally and disproportionately affects groups in Australia like our Aboriginal and Torres Strait Islander populations. So this scoping review argues that tackling menstrual stigma and misinformation requires change on many fronts. And one piece of that puzzle could even be school-based menstrual health education. This would be an important step towards giving young people the language, the knowledge, and the confidence to seek help early. It also lays the groundwork for broader public health awareness, which could lead to earlier intervention and more empowered patients. And isn't that always the goal? So what Women's Health Road showed me is what great care could look like when menstrual health is taken seriously and prioritized. And it reminded me that as future doctors, we're not just treating symptoms, but we're also shaping culture. Yes, even at a medical student level. So to all of us here, med students across Australia, I'd say this: even if our curriculum hasn't fully equipped us yet, we still have the chance to fill in those gaps and be a part of the solution. We can ask extra questions in class and on placement. We can believe women when they say that their bleeding is impacting their life, and advocate for more training and better models of care in our future workplaces through university and placement feedback forums, and simply just continuing the conversations that we've had here tonight, because it doesn't end here. And because menstrual health is so much more than just a niche topic, it's a core part of women's health, public health, and everyday well-being, and it deserves an increase in advocacy, awareness, and education. So thanks for listening, and I'll pass it back over to Paula.
Thanks so much, Sophia. And I hope everyone really enjoyed that patient experience. Unfortunately for me, that wasn't my experience. I lived with heavy menstrual bleeding for over 3 decades, and thank goodness a couple of years ago found a really great gynecologist here in Adelaide who had a very similar
Sorry, sorry, Paula, you just muted out.
Sorry, where did I get to? Maybe. So yeah, 3 decades of heavy menstrual bleeding. 2 years ago, I finally met a gynecologist after seeing many gynecologists over the years and GPs who really just accepted it's just something that happens, and some women have heavy menstrual bleeding, and the options were only ever birth control that were provided. So Dr. Dean was absolutely spot on. Post my hysterectomy, I was diagnosed with adenomyosis, and it really just explained so much, and the freedom that I have now. And this is why I'm so passionate to talk about this with, women of all ages, because sometimes we would just push through things, and if we're not getting the right answers. So I really encourage everyone on this call to make sure that when you're talking to women, please believe them, take their history. We battle on, and we have big lives to deal with. The other thing that really, I guess, is a challenge for me is the generational impacts for both my children. And I have a daughter and a son, and when my son was younger, he was diagnosed with an iron deficiency, so we had to, we were able to manage that with food, and obviously he doesn't menstruate, so that's stable. But my daughter did have some heavy menstrual bleeding, and a Marina was absolutely amazing for her. And we did also find out through a hematologist that she had some platelet issues as well. And as she's going into her second pregnancy, she's very well aware of how to manage that, thanks to some great care. So I just want to thank everyone today for listening and really ensuring that patient care history is just such a critical component when treating patients. Thank you.
Thank you so much to all of our panelists for bringing us along on that patient journey. And as Paula and everyone have mentioned, what we did showcase through this little show and tell of patient journey was that if you get the right care, and if your doctors have taken the right history and they've referred you to the right specialists, patient care can look like this. But unfortunately, that's not what it looks like for most women. It definitely wasn't the case for me, and it definitely hasn't been the case for women that we speak to. And at the end of the day, I think having medical students on here, the important thing to take note is that history taking is incredibly important. And what we take away from this also is that there's such interdisciplinary care that happens for women's health. It doesn't start with a GP and end with a gynecologist. There's so many other moving parts and so many other specialists that are involved in making sure that we're taken care of holistically. And I hope that this patient journey presentation was a unique way of showing all of us what patient care can look like, what it should look like, definitely, as we go on to improve our healthcare, but definitely, as we heard from Sophia, what we should do as medical students throughout our school, and how we can make better use of our education, going back, asking the right questions, getting involved in these spaces, and ensuring that we begin the conversation now, because if not now, then when? And with that, as we were going through the patient journey, we definitely had a lot of interesting questions come along. And this is when we're going to present the opportunity to everyone to start asking questions. So if I could request everyone to get onto Slido, scan that QR code, drop in your questions. You can upvote questions, and that would allow us to have a moderated session where we can field your questions to our panelists, and we can make the most out of this interactive session. Just to begin, while everyone is keying in their questions, we'll start by asking a few buffer questions, and then we'll move on to your questions as well. Ari,
hi everyone. Nice to meet you all. The first question I have is for Dr. Megan. As a GP, could you expand on what are some of the challenges a GP may face when managing heavy menstrual bleeding in rural or low resource settings?
Yeah, so definitely. So I think one of the main issues, especially in low resource settings, is time. So, and I'm guessing you would have seen a lot with the election that that GP rebates haven't been indexed to inflation. So it means that in order to keep a general practice viable in most cases, you either need to see a lot of patients per hour or you need to charge a gap fee. And that means that sometimes if you're charging, and there's pros and cons to both of those things, but sometimes when you're charging a gap fee, it means that some people are missing out on seeing a GP. If on the other hand you're not charging a gap fee, you are often under pressure to see a lot of patients per hour. That sort of limits the amount of time that you can spend with patients, and that obviously gets in the way of taking a good history and building a relationship with a patient. So if you're not taking that good history and not building that relationship with a patient, then you're not getting the answers. And the other thing would be in rural and low resource settings is sometimes there can be big waits to see to see a gynecologist or to see other specialist services, and can sometimes be a very long distance from home. It can be a day's worth of driving, or a long distance flight, which can be very expensive.
Ariane, may I add to those excellent points that Megan has made? So there is this document called the Heavy Menstrual Bleeding Standard, and this has been developed by the Australian Commission of Health and Safety in Healthcare. So basically, this was initially developed in 2017, and in response to the fact that geographically our rural and regional communities were having, a different sort of, for example, if you look at hysterectomies, they were 6.6 times higher in rural areas. Now, each one of those basically medical, surgical, and radiological have their pros and cons, but ideally we want all women to have all options so that they can then select and do shared decision making with their clinicians. And so this standard basically highlighted that wasn't happening, and they weren't getting the same access to lower tiered care, which included, like I mentioned, the polyps, fibroids, and ablation, endometrial ablation, and radiological embolization. So then there has been a revision of this document again to say, look, it's important to encourage lower tiered options in general. And this is not, it's not a hard and fast rule, but it's basic. And obviously there's so many women that are better matched to a hysterectomy, but in general, we should have the lower tiered options available for women so that they can consider those. And if they don't want that and they want a hysterectomy, or the clinical picture or the circumstances are better suited to that, for example, worried about a malignancy, significant pelvic pain, someone who's tried everything hasn't worked, or wants that definitive surgical support, then, but not for want of not having an endometrial ablation is what I'm trying to say. Thank you.
Okay, thank you for.
Sorry, go ahead.
Oh, do you want to say anything? Sorry.
I just wanted to field on the next question. Go ahead.
Okay, the next question is, Does the uterine ablation treat adenomyosis?
So if it's okay, or Dina, you okay if I take this?
Go for it. No, you go.
Okay, all right. So an adenomyosis is when the lining of the uterus, as we discussed, is in the muscle. So it's primarily a muscular problem. So if we're going to denude the lining using heat or some form of treatment, we're basically it's a very silly analogy, but I explain it to my patients by saying, look, we're doing a lawn mowing, but imagine if we're taking off the top layer of the soil as well. So, but we're not actually taking out the muscle of the uterus. Now, I do offer it's not a contraindication to adenomyosis, but it is to endometrial ablation, but it is important for women to understand that their pain may get better or may get worse, because there is something called a post-ablation syndrome in which, women's pain gets worse. So we can't really compartmentalize the symptoms. So, saying, well, we're going to sort out the bleeding, we're not going to worry about the pain. But for many women with adenomyosis in our practice, we find that they actually quite benefit from the adenomyosis, because not everybody's, unlike Paula's situation, which was actually quite symptomatic for pain. Many women have adenomyosis, they actually have very minimal pain. And so we do offer an ablation, and sometimes we offer an ablation and for example, an IUD or hormonal support. So yes, you can use it with adenomyosis, but there's a slightly higher chance of this not being as successful as we wanted, not from a bleeding context, but from a pelvic pain context.
Yeah, exactly. I just wanted to add as well that, it's falling pregnant after an ablation is also not great. It can affect the placentation. Yeah. And, often you put a Mirena as well. And often, for a contraception, often adenomyosis responds so well to a Mirena that's, I kind of think, as you mentioned, it's trying that first, but it can really work out really well, and it avoids a hysterectomy. And I think that if you can avoid a hysterectomy, better off doing it. And if you end up having pain ongoing, then unfortunately a hysterectomy is required, but it will cure that at least. It's not something that won't get better without, hysterectomy.
Thank you so much for that. The next question that we have that's coming in, who should be referred to a gynecologist versus who should be managed by a GP?
Everyone should be managed by a GP. It should go to GP first of all. Yeah, go for it. I think yeah.
Oh, thank you, thank you. So yeah, the GP will do the initial workup, and so I think the people that should go, anyone where you have a high suspicion of malignancy should go to a gynecologist. If the ultrasound shows any abnormalities, so increasing thickening of the lining of the uterus, that should go to a gynecologist. Things like very big fibroids, if you see structural causes on the ultrasound, then that's a referral to a gynecologist. And the other thing that sort of automatically is a referral to a gynecologist is if they're wanting procedural options, if they're wanting an ablation or a hysterectomy, then that's automatically a referral to a gynecologist, or if the patient prefers to see a gynecologist. The other thing is if all the investigations are normal, then if a GP does do Mirena insertions, and the patient would like to try that, that's something that can be done in general practice if the GP is trained in doing that. Or you can try other medical options like the pill, tranexamic acid. Talat and Dean,
if let's say you've tried all of those and it hasn't worked. So the original HMB standard, when it was released in 2017, said after 6 months, but then on reflection it was recognized that we don't want women to wait 6 months if we're not winning. And number two, some women might, it's a very individual decision in terms of some women might want to refer to the gynae clinic early. And so to leave that up to the GP and the woman to finalize when to refer outside those excellent points that you've made, Megan.
Yeah, good GP
so there's
is
no
critical in all this. Yeah. Yeah, just saying good tip is so critical in this because often people don't try very simple things. You know, the Ponstan pill can work so well, and tranexamic acid can work so well, and they're things that can be trialed very safely, as long as a structural thing is not missed, and as long as the malignancy is not missed. And you mentioned ultrasound, super key for the medical students. Also make sure that it's a transvaginal ultrasound because you can see much better. So when you're doing your vivas and things like that, if you request a transvaginal scan, you'll look like, you look like you're really knowing what you're getting into the cause of it. And it's really key to get that information. And the other thing that is a little bit ideal as well, you mentioned structural things. Pretty often I get patients that have fibroids that they're watched for a long time, and they watch them until they get to a size that's so big that only I'm stupid enough to try and take them out. And I do wish sometimes that people saw me 5 years earlier. And you know, one of the just reflecting on, you know, what Paul was saying about, you know, 30 years of experiencing this. Sadly, that's not uncommon. Sadly, we see, like, one of the most common things that I hear from patients after hysterectomy is, why did I do this 10 years ago? It's like a really common response that I hear. And, you know, I'd say, sorry, it's better late than never. But yeah, delaying those appointments to get the help, I think, is a really big negative thing, and unfortunately very common. But if the simple treatments can work really well, and definitely try them first, and then timely approach, as Megan was saying.
Thank you for that, Dr. Dean and Dr. Megan. The next question we have is apologies. Is there a contraceptive? What are good options for contraception that can be used if the patient has headaches and migraines besides the Mirena?
Okay. Or Megan, did you want to take that, or are you happy for
So the risk with migraines specifically is migraines with aura, and the reason is in patients that have migraines with aura, they can't use oral estrogen. So the oral estrogens in the combined contraceptive pill do increase the risk of embolic stroke. That's the reason we ask about migraines specifically. Migraines without aura or headaches, those patients can sometimes use the combined pill, but you know, sometimes some women are still sensitive to the estrogens in that, and they might prefer a different option. There is, if they're not wanting the combined pill, there is obviously progestogen only pills, and there's a newer one called Slinda, which contains drospirenone, and it's it's recently on the PBS, and it's quite good to try for. It's worth trying for heavy menstrual bleeding. Some of the older progestogen only pills I find are not as good for heavy menstrual bleeding, and the other options are other options like Implanon and the Depo-Provera. The bleeding can be one of a big side effect why women choose to discontinue the Implanon, and so some women stop getting periods altogether with the Implanon, so that can be a good option, but it's not always a good option for heavy menstrual bleeding. And then with the Depo-Provera, which is the injection, there are other issues with that, concerns about bone density in long-term use, but it is sometimes an option for short-term if somebody's needing short-term contraception. Anything else to add, Talat?
I think that iron deficiency sometimes itself can be leading to the headaches. And in my experience, in my clinical experience, I find that once we get iron neutral state, that many women's headaches actually get improved because it was a multifactorial reason for that. And usually I just say, look, it's a matter of us trying to find that Goldilocks point with you. So it may be that we start with one thing, and that's one philosophy that I've learned with heavy menstrual bleeding is that try and create a plan A and a plan B. So even when we're going to theater, for example, if we have an ablation plan, I'm like, okay, what if I look inside and I think I'm worried about, whether there's some pre-cancer or for some reason, technical reason, it's not an appropriate cavity for that, then would you give me permission, for example, to put in a Mirena? So I try to encourage women to think very solidly about what is their plan A, plan B, and plan C. And I think that's the bleed better philosophy, because it moves us away necessarily from the tool that we're going to use to achieve quality of life to the fact that we are prioritizing quality of life and saying you should demand a good quality of life from the healthcare system.
Okay, thank you for that. Are we able to move on to the next question now? Okay. I had to rephrase this question a little bit, but the question is, I know there isn't a pelvic health physiotherapist here today, but if anyone knows how pelvic physiotherapy can help with heavy menstrual bleeding, please share.
Okay. Dean, did you want to take that, or you're happy for me?
You go for it. I was more talking about endo and adeno and things like that.
Yeah, exactly. So half of the time in statistics, heavy menstrual bleeding is associated with pelvic pain. So the role of physio is multi-layered. So for example, my interest is particularly in perimenopausal women, and I find that I learned so much from our physio in our team, in our MDT, and she helps women not only with the pelvic pain, the endo, the adenomyosis, if they're choosing not to have a hysterectomy, for example, but also around other bigger picture issues around continence and prolapse and associated any sort of almost like a well-being midlife check. So what can we do now and put in good strategies around pelvic floor health that our future self will thank us for? Remember, now the average age of longevity is 85. It's increasing for women. So we don't want to just live a good health span. We actually want to be, not just a lifespan, we want a good health span for everyone. So in terms of the heavy menstrual bleeding itself, I mean, I guess any pelvic floor health does optimize in general well-being of the pelvis, but I'm not aware that that specifically reduces the bleeding or any of that sort of benefit, but it's more holistic therapy that supports the pain part of it.
Thank you so
Dean.
much for that. Oh, did you have anything to add on, Dr.
Dean, anything to add there?
No, it's 100%. I think that the and with Paula's story, the adenomyosis as the cause, 50% of the time they'll have some endometriosis as well. And it's an inflammatory condition that makes the pelvic nerves flare up, that activates pain. Then the pregnancy associated pelvic floor issues. Nearly everyone I see sees a pelvic floor physio because it's so all encompassing. I agree the pelvic floor physio is not going to help minimize the bleeding you're experiencing. That's one part of a bigger picture. So I think there's value there for pelvic floor health experts. Yeah.
Thank you so much for that. I think the next question is very interesting and going to be very important for medical students. And I think I'll split this up into two parts. Firstly, address to Sophia. How can medical students get more involved in this space? Obviously, we don't get to spend a whole bunch of time down at the hospitals facing women's health cases unless we are on our obs and gynae rotation. And even then, we don't get complete exposure. So how do you think we as medical students can get involved? And then the second part of the question leading to Dr. Dean, because I know you do some clinical education in this space, how can we as students learn to take better history, ask the correct sexual health and menstrual health and menstrual history-based questions for our clin skills and also for our OSCEs that would then help us become better clinicians? So over to you, Sophia, and then Dr. Dean.
Sure. So I'll start with the med student perspective here, and I'll kind of divide this into things you can do for self-directed learning and then how to make most of your clinical exposure when you get to that point in medical school. I think maybe a lot of people on here are preclinical, but you'll get a lot more exposure to obs and gyn later on in the years. So in terms of self-directed learning, things you could be doing right now or before your rotations start, you want to understand the obs and gyn pathologies the best you can. My favorite resources are like osmosis or pathoma and first aid. They've all been really helpful in my learning. Reading up on the RANZCOG guidelines is also really helpful, or therapeutic guidelines. Just being really familiar with the language of how these things are talked about, how they're typically treated, is just going to make your learning on placement when you get to that point a lot more efficient. And then in terms of when you're on placement, you want to make the most of the clinical exposure that you do have. We can never perfectly control exactly what we get exposed to, which is why the self-directed learning is pretty important. But before you get there, you want to practice taking a great menstrual history, which we'll hear from Dr. Dean right after, maybe some of the things we can be thinking of. You also want to be keen on placement, ask questions, and reflect afterwards. What did you notice? What did you learn today? I love to keep a notebook on me at all times and just write down things that I'm noticing. Yeah, and be reflective of broader like social and public health things that you notice as well, because that informs what gets prioritized from a public health standpoint. And that might help you realize what your own interests are and where you want to go further. If this topic doesn't get covered in your med school or you're not seeing it on placement, I would let your faculty know in the feedback forms that we get to fill out, just so that they're aware, because it is something that I think should be prioritized in education. And then lastly, I think people can get involved in, things like this, like AMSA SRH is great, or charities like Bleed Better, or look for research opportunities once you have kind of more of an understanding of how this works, or if there's a particular pathology that specifically interests you. And these kinds of things sort of help network and gives you exposure, which is how you figure out if you like it or not. So that's my initial thoughts on that.
And about the history taking, so you saw great examples today of history taking, and it's so important. It's one of the most important skills that if you end up doing clinical medicine, not everyone that does medical school ends up being a clinician, but if you're doing clinical medicine, taking good history is just so important. And part of that is making sure the patient feels heard. As you heard today from Paula, she, I think, spent years not being heard. And again, it's sad to say, it's not uncommon. I hear this all the time, that the people aren't heard. So allowing the patients to explain what they understand of things and what's going on is a really good way of doing so. The trouble that I'm talking to a bunch of students here is that the women's health history is complicated, right? You have, like any history, you've got your presenting complaint, then you've got your past medical, past surgical, allergies, biopsychosocial, all the things are standard. But women's health history have a whole bunch of other stuff. You have your menstrual history, okay? So that's a whole thing in itself. And as you can see, it takes a long time to take a good menstrual history. On that part, I just want to say, we talk about what heavy menstrual bleeding is, like what the definition is. And we talked about, there's so many things that people talk about measuring how much blood, 80 mils per cycle. Like you can imagine people getting menstrual cups and tip it into a measuring cup or something, or like weighing how many pads that you have, or measuring your iron, or measuring hemoglobin. It's heavy if the patient feels it's heavy and it affects them. I think it's really important to know that the definition is if it's heavy enough that it impairs their life. And so that's why it's important to say how it affects them. And you heard that really great, how Dr. Megan really got to the bottom of how much the bleeding was affecting Paula. So back to the history. Menstrual history is one big one. Then you've got your obstetric history, which can take a whole bunch of time as well. You've got your contraceptive history. You could have tried all these different contraceptives. There's a sexual history. Then you've got your menopause history. You've got your pelvic floor history. You've got to talk about the bladder and the bowel function. It's so many parts. Your screening history, talking about the cervical screening test and the breast screening and the bone density. There's so many parts of a women's health history that, as Dr. Megan said, working in a low resource setting, you got 15 minutes to see a patient to get an idea. If you're in an OSCE situation or Viva, you got 5 minutes to get a history properly. And it's very difficult to get a good understanding of a history. The little tips that I say for the students is try and think about women in 3 different scenarios, because you usually get there's women at different phases in their life. And so I think about, first of all, a non-pregnant reproductive age woman. You're focusing more on their menstrual history, their contraceptive history, their sexual history. Then you've got your postmenopausal woman. Yes, their menstrual history would have been important, but now you're focusing on their menopause history, the pelvic floor history. Then you've got your pregnant patients, you're focusing on obstetric history. So if you're having one of those 3 people in mind, can help you tailor your history a little bit more. Not to say that a sexual history is important for someone in their 80s. I've had lots of patients in their 80s that are having sex every day. And you've got to take these histories properly, but when you've got a short period of time, you have to kind of think, how am I going to best get to the bottom of what the issues are? And I think putting in your mind one of those 3 scenarios to really be able to focus on what you want to get out of the history is really important. And getting that good history is just so essential, and we do it every day. So learning it well is valuable for later. So it's not a useless skill to focus on.
May I add a few words to the amazing points that Dean has made? So in a practical context, I'm an ambassador for Heidi Health, which is one of the AI scribe companies in Australia. What we have done is we have entered some of the history parts that are really important into the template. So for example, FIGO that I mentioned earlier has some parameters on what a normal cycle should be. And that is, for example, the duration should be ideally less than 8 days. So that is entered. So if the woman says, look, she's bleeding for 9 days, it triggers that as an abnormality. Is the cycle regular or not? How frequent is the cycle? So is it coming around less than 24 days apart, or on the other hand, more than 38 days apart? And then, what is the volume like, which is very subjective in terms of light, normal, or heavy. So what we are doing in a practical sense is that we are obviously taking that history, but we're also using technology to trigger us to say, hey, hang on, did I remember to ask that particular question? It was so relevant. So then I think that is the best way to use technology, where the clinician is still very much in the driving seat, but it is there as to support the care.
Thank you so much, Sophia, Dr. Dean, and Dr. Tallet. The next question here is there any recommendation for evidence-based supplements for women who have heavy bleeding to prevent anemia? Obviously, like following blood test info and things like that.
Megan, did you want to take that? Or actually, Anastasia can tell us about iron and supplements.
Yeah, unfortunately, there is. This is if you have. So I'll just take a step back a little bit further. So if you have a look at internationally, there's 16 different publications internationally that talk about heavy menstrual bleeding. Only 4 of those 16 say we should do iron, hemoglobin, and iron screening. 2 actually explicitly say do not do iron studies to screen a woman until she presents with anemia, and then you can investigate subsequently. So there is this gross discrepancy against peak professional bodies guidelines about how to recognise and manage women with heavy menstrual bleeding and iron deficiency. In my practice, like I said, I only work at a women's and newborn hospital, and 40% of my women have iron deficiency, and that is in a well-resourced metropolitan centre, and that's because they have had heavy menstrual bleeding that hasn't been optimised, or they're pregnant, or they've had recurrent pregnancies that we never really top up their iron to adequate levels. So unfortunately, there isn't evidence-based guidelines about how to prevent iron deficiency, really. We know that at different stages of women's health, they do need different iron. There is different iron demands, and so usually a woman. Sorry, that's my dog wanting to contribute. So usually if we look at the daily recommended intake of iron, it's about 1.6 grams per day for a steady state. And during pregnancy, that increased to 4.4 grams per day. So kind of more than kind of triples to quadruples based on needs at that time. And so I would really advocate for frequent assessment. And if somebody is presenting with heavy menstrual bleeding, unfortunately, you do just need to monitor. And there are guidelines about how we can approach the management of women, how we can treat women with iron deficiency during their reproductive age. But it's not a population-based assessment. It's really about somebody presenting with a problem and how you can optimise them. Keen to hear if Megan's had a different experience, or Talat or Dean.
I think was the question, Vienna, around supplements, around natural supplements, or it was around?
Oh, sorry.
What was it, the question again, please?
Yes, so the question was regarding the use of evidence-based supplements for women who have heavy menstrual bleeding to prevent the resulting anemia.
So I think Talat's trying to pull out that some of those natural supplements just don't have adequate amounts of elemental iron to actually make any difference on your iron stores. And so most would say if you're talking about prenatal vitamins, there's only 5 milligrams of elemental iron, whereas most of the time the proper iron oral supplementation has between 60 and 100 milligrams of elemental iron. And you really do need to have the therapeutic oral doses to try to correct iron deficiency. But unfortunately, if a woman has got heavy menstrual bleeding and has progressed to the stage of anemia, it's unlikely for you to optimize her iron stores to manage her, not only have normal iron stores, but actually fix her anemia with oral iron as well, unless you get on top of that heavy menstrual bleeding. And so it's really an absolute two-pronged approach. And I absolutely loved when Megan talked about, yes, let's give you something to start to reduce your blood loss and address your iron deficiency, because I think it should always be that two-pronged approach, because and I think Paula said it was like a bucket with holes in it, so it didn't matter how much iron she was getting topped up, it just fell out because of the heavy menstrual bleeding. So I always have the approach of treatment for the underlying cause, but also addressing the deficiencies as well.
I agree with Anastasia. Just this week, I've seen, and she's allowed us to share, our medical students actually writing it up as a case report, a young girl with hemoglobin of 8 and ferritin of less than 5. And so basically no iron and really anemic. And again, has had a year of going through various natural supplements from the naturopath. Again, everyone has a role in health, and we're very respectful of that. But I think heavy menstrual bleeding to a point that it's causing this much anemia really should have medical support very early. And so that was I think that's the take-home message. And the other person I've seen very recently is 36 infusions. Now, that is not good medicine. Okay, if we're doing 36 iron infusions, and I think that it's so important, and the person doesn't know all the options available for her to support her, I genuinely don't think that is good medicine. So we really need to do better as a medical community, and also in raising awareness, so that women can then, it really shouldn't be up to the women to be saying, look, what about this, what about this? We should be proactively offering, but at least if the women have a full idea of what the spectrum of options are, then they can also be an important advocate for themselves, sadly.
Okay, thank you so much for that. The next question is, and I had to modify it a little bit, how can we help women to understand what is a normal amount of bleeding, especially if they don't talk about it with others? And are there easy ways they can measure their own blood loss at home? I think Paula could probably answer this, as she can share some insights on how learning about normal blood loss helped her understand it a little bit. So this is a question for Paula, I think.
Can you hear me? Thank you. I think it's really, and I actually cut and pasted and put this in the chat, so if everyone wants to go and grab it. But there's a really great slide that Bleed Better and Women's Health Road users, and it's around the red flags of HMB. So really it's for women to understand, is your bleeding affecting your daily life and overall well-being? Do the periods last for longer than 8 days? Would you describe your periods as unusually heavy? And I think once you start having a conversation with a woman, they'll start sharing that they're losing clots, or, you know, if they pull their pants down not quick enough to then sit on the toilet, you know, it can flow out onto the floor. You know, blood clots larger than a 50-cent coin. If you need to use 2 types of menstrual products at the same time. So, you know, as I shared earlier, you know, I'd use the heaviest tampon available and then use a, you know, a maternity pad so that I wouldn't bleed into the bed, and, you know, I'd wake up hopefully with enough time to get to the bathroom to change in the middle of the night. You know, if you're changing every couple of hours or less, then, you know, that's not normal. If you experience leaking through clothes and bedding, you know, the amount of times I've felt the shame and embarrassment because I have, you know, had a flooding event somewhere out in public. It's been, you know, terrible, and thank goodness, you know, had some supportive people around me to help me manage that as well. And just that overwhelming sense of being tired and drained of energy. I think a lot of women wear that as a badge of honor. You know, we live in a different world now. We've got big jobs, you know, big families, big community groups. We manage a lot. And so if that is impacting your day-to-day life, which it absolutely was for me, you know, hindsight's a beautiful thing. I'm on the other side now, and hence why I'm so passionate about this, because no woman should have to put up with what I went through for over 3 decades. But it's just, you know, it wasn't just me, it was everybody around me sort of experienced that as well, because if I'm not at my best, how can everyone else be at their best as well? So I think it's really important. And just, you know, in the history notes, I think we just talked about it earlier, and I nearly had a heart attack when Dr. Talit shared, you know, 37 iron infusions. I've had over 10 myself over that 30 years. And a lot of the time the GP who said, oh my God, you know, your ferritin is, you know, below, you know, sitting at 4 or something ridiculous, we need to get you an iron infusion. They never asked if I'd had one before, or if, you know, how recent it had been. You know, medicine's changed, gone are the days of family doctors. So it's really critical to draw out that from women, because, you know, we're more transient, we move a lot, and we don't always, you know, our medical records don't always follow us where we go. Thank you.
Thank you so much for sharing that. The next question, and I think I'm gonna, and this is, I think, very important, bring back to, we've brought up iron infusions a couple of times. We've also spoken about supplements. What is recommended for someone who has heavy menstrual bleeding plus very low iron, and when they're not eligible or counted as eligible for an iron infusion until they're clinically deficient? So, you know, again, linking back to what are the treatment options for someone in that space, and then also, is there a possibility that they may have gradual decrease of that iron and they may not be responding to supplements? And I think this is something that med students face in our curriculum. We aren't educated much on nutrition, and nutrition is so incredibly important to support the women, as you know, she's trying to get her iron intake there. Supplements and medications can't be the end of the world. So if we could elaborate a little bit more on how we can improve our nutrition as well, our dietary intake, to supplement all of these other treatments as well, I think that would make for a great question.
Anastasia, a bit to you.
I think I'm not sure if I'll be able to add a lot more other than, so the concepts of what we were talking about before, I think, is still really resonate. And I think if you have excess blood loss, that is a different story to if you're having normal physiological demands of normal menstrual bleeding versus abnormal or heavy menstrual bleeding. So I think the root of all health and well-being should be a balanced diet, where you do try to eat a good balanced diet, and that should include either heme or non-heme iron. And your body does an amazing job of regulating and recycling iron from your senescent red blood cells. So about 80% of your iron in your body is actually from recycled red blood cells. You do an amazing job through the reticular endothelial system of the liver and spleen of recycling that iron. And you only actually need to absorb 2 milligrams of iron, sorry, 2 grams of iron, 2 milligrams of iron every single day to maintain that during a steady state. And it's really during those, there's about 3 or 4 times of life where those are challenged. And one of them's in infancy, where there's the growth spurts. One of them's during adolescence. Then for females, it's menarche and babies. And they unfortunately they're described as physiological changes, but they're not always physiological. So I think outside those increased demands or increased losses, a balanced diet is really important. And I always, and Talat knows that I always share with my women, I've got this lovely little pamphlet that describes the actual amount of elemental iron in the foods that we eat. So if people are eating a balanced diet, they're making good decisions. So if you are a vegetarian or vegan, you'd be fascinated to know that 3 Weet-Bix has the same amount of elemental iron as 150 gram steak. And so it's kind of making those good decisions about what foods you can have that are iron rich. But I would say as soon as you're moving to areas where you're not just having either physiological iron losses through a steady state, I think you do need to screen people for iron deficiency and or anemia. And if you are detecting iron deficiency, then oral iron replacements with elemental iron doses between 60 and 100 milligrams is what you would need. And most guidelines would say if somebody was symptomatic, had a hemoglobin less than 17, was iron deficient, that would usually warrant an iron infusion. Or if they were particularly symptomatic, or they were going for surgery, or they're in the 2nd or 3rd trimester of pregnancy. And I can unpack how people tolerate iron or not, but I might just pause and let my other panelists contribute to that.
Yes. And one thing I wanted to add, Anastasia, to that is that the ferritin range is actually quite wide, and the Royal Pathology College recommends 30 microgram per liter as your lower reference range for ferritin for all adults. Now, one of the Bleed Better projects, ironically, it's one of our wonderful medical students that's running with this, with a lot of supervision from a hematologist and myself, and including Anastasia, is that some labs in Australia have chosen to use 15 micrograms, which is the WHO recommendation, because obviously they're looking after least low resource countries as well. So they have a more global focus for women. So now the women that are bleeding, we are now giving them the lower threshold. So there's actually an iron gap. And I've personally written to a number of labs to say, when the pathology college recommends using 30, is there a reason that we're just for women using a lower threshold yet? So then I see women that have been years that are iron deficient, and they say, oh, I thought I had heavy periods, but then my GP said, no, I didn't. And then my iron has been normal. And I'm like, no, it's not normal. You've had 22 and 27 and 25, and it's been going on for 6 years. So I think that these kind of, we've got to really think of all of HMB, and how do we look at iron deficiency as something that's endemic, and how do we support this as a public health issue? And I think the minimum the women deserve is the same consistent yardstick. And I think gender-based, I've actually said to women, if you were an Australian man, you would be diagnosed iron deficient. Now, because you're women, this lab has now chosen to use 15.
Thank you, Talat. That was excellent advocacy. But from a biology perspective, this is quite fascinating that they've done really lovely animal models that actually, so if you think back to your the absorption of iron across your proximal duodenum, and we know that once your ferritin gets less than 15 micrograms per litre, you actually have an increased expression of your, you have a decreased expression of your hepcidin, an increased expression of your ferroportin. So biologically, the flip of iron deficiency is 50 microliters per litre rather than what we're diagnosing as iron deficiency with a ferritin less than 30. So when I see and hear ferritins being diagnostic with, ferritins less than 15 micrograms per litre, that makes me particularly distressed. But like you said, that's based on WHO, where you have very resource. They're basically saying if you have a ferritin less than 15, you can be nothing but iron deficient, whereas a ferritin of 13, you're probably iron deficient. But biologically, you have changes in your expression of your ferroportin or your hepcidin once your ferritin gets to 50. So I would absolutely advocate not to wait till you get all the way up to the absolutely bone dry state when you come to your own stores, and be more proactive much earlier on.
Thank you, Dr. Anastasia and Dr. Tallet. I've clearly got a couple of flashcards I've got to review about iron absorption, and I'll go do that tonight. So I've got a couple of questions here that relate to different procedures. The first one is for Dr. Dean, and it's I was just wondering whether you could clarify what you meant when you said a hysterectomy could proceed as long as the uterus fits in the bag. And the second question was about performing ultrasounds. So the timing within the menstrual cycle for undertaking an ultrasound for those with heavy menstrual bleeding that'll best kind of elucidate what might be going on.
So I'll answer the surgical question. So with the minimally invasive approach, we make incisions of as big as 1 centimeter on the abdomen. And if you've got a uterus that is up to 20 centimeters in size, how do we take that out of the body? Generally, the biggest hole that we make is at the top of the vagina. So it's about a 3 centimeter incision at the vault. That's where we detach the cervix from the vagina. And that's usually a good place to try and remove the uterus through. But if it's 20 centimeters and if the patient has had cesareans only and they've got a narrow vagina, then you've got a situation where you've done this really good surgery to detach the uterus from the body, but then how do you then get it out of the body? In the US, I think it was 2014, what happened was they were doing something called morcellation, which is the fancy word of cutting it up into little bits. And what you do is, if you morcellate it, there's lots of different ways of doing it, but essentially you're chopping it up into a long sausage. I saw those pictures that I showed earlier of us holding up quite long specimens, which we're very proud of to get out of the body. But the reality is, if someone's got an undiagnosed cancer and you chop up that cancer, you've changed someone's staging from a stage 1 disease, which is confined to the uterus, to a potentially stage 4 disease. You spread it throughout the abdomen. And in the US, that happened in I think she was an anaesthetist or a cardiologist, and then there was a huge lawsuit about morcellation and its impacts, and morcellation was banned in the US. It was actually Australia and our group around 2017 that started doing this contained in bag morcellation technique, where we would put the uterus in a bag. So put the bag inside the tummy, put the uterus in the bag, and then bring the bag or the mouth of the bag either out of the belly button or out of the vagina, and break up, do the morcellation inside the bag. So any cells that spill around, they get contained in the bag. So if there is a cancer that's undiagnosed, it gets collected and contained, not spread. So it's very important that we do all those procedures in a contained morcellation technique. There's still not a lot of evidence to really just confirm that's 100% going to be successful, because you still can have spread of tissue even with your best aims to get this under control. But it's a good idea to try and do it as best you can. And the other thing that can happen is you can get parasitic fibroids. You can get benign fibroids spread and grow on the bowel and other places. So even benign conditions can spread. So the answer to the question is, with big uteruses, we want to morcellate, but often in a contained fashion. And there's lots of good videos and pictures that I can share with people about that process. And it's quite challenging to do and takes a lot of work for us to do it, but patients really benefit from it, where they would have had a big 20 centimeter incision for a 20 centimeter size uterus, which is a week in hospital, 6 weeks off work, to a 1 centimeter incision, which is home the next day and back at work pretty quickly, if that's what they want to do. The other question I forget was about something about ultrasound.
Yeah. So the ultrasound is best done, thanks, Dean, on day 5 to 10, because the lining is the thinnest. So it's almost like, again, to the women, you're going to think I'm so obsessed with tradie. The gardening concept, like if the lawn is really overrun, it's hard for us to see the weeds. So I say to them, look, that's the time in which your lawn is the most likely to be thinnest. And so if we've got any nasty weeds, they're easier to see. So the polyps, the fibroids, possible cancer, it's just easier to see. However, some women don't have those typical heavy bleeding in terms of cycles, and the cycles are all over the place. And so I just say, look, in that case, just do it when you can, and let's get what information we can get. We can't always wait for that perfection of day 5 to 10, just after the period when the endometrial lining is the thinnest. And sorry, one more thing. Whenever we're treating heavy menstrual bleeding, we always want to be sure that we have ruled out the potential for a pregnancy, and this is not a miscarriage that we're mislabeling. And also STIs that we've kind of thought through, that we're not missing. And typically, that's heavy menstrual bleeding is not a real manifestation typically of STIs, but it is important to keep that at the back of our mind, that we're not missing anything else that this woman might have.
Yeah, good points out for the students. Assume everyone is pregnant, all right? Missing a pregnancy can be a really dangerous thing to do for both a pregnancy and a woman. So always assume people are pregnant. A bedside urine test is very accurate. So yeah, I think that's a good point for the students to always take away. Assume everyone's pregnant.
Thank you so much for that, all of our panelists. I think this has been an incredibly informational session. I've had friends texting me throughout the session. Thank you so much for organizing this. I'm down here based at Flinders, and just a couple of weeks ago, we did 2 weeks of hematology. All of my colleagues in different universities have either done their obs and gynae rotation or blocks, and done this block. And I think everyone has found it so incredibly informative. There's a lot of this that we don't cover in our medical education, and then we step out, and I've heard from seniors time and time again that they've seen cases they've never heard about theoretically, and then they don't feel confident enough as medical students to be stepping out there, or to entrust themselves to patients to be able to help them. And so I think the fact that we got this event going, and the fact that we had this conversation was so incredibly important. I just hope that we managed to inspire everyone to keep the conversation going, keep learning, keep involving yourself, because at the end of the day, that's the only way we're going to become better clinicians. And I hope what everyone took away from this was that taking histories are extremely important. You can be the best specialist out there, you can know how to do your surgeries, but at the end of the day, if you don't know how to listen to your patient, time and time again, that has come to backfire both the patient and the doctor. And I think that's what we need to learn from here. Listen to your patient, listen to yourself as the patient. So listen to your body. If you know something is off, don't keep thinking this is fine, and will go away, and then wait for it to become worse, and then have to deal with the much terrible consequences. I know people, I've done this myself, and I never want to do it again, and I hope everyone learned that from here. Thank you so much for everyone who asked questions. There were so many more, but unfortunately we do have to sum up the event. If you do have any questions that you definitely want answered, please feel free to email us. We will definitely email it to our panelists, and we could post the answer on our social media. You could follow us on your AMSA SRH, and we could answer your questions over there. Just to end up this meeting, could we please give a round of applause to all of our panelists who took the time out after their busy schedules, an entire day of work, to come here and educate us and spend time with us. And I could request everyone who's comfortable to maybe switch on your cameras so that we could take a little bit of a picture. And then we could end the event. So everyone pretend cameras on, take a picture. There we go. I'm gonna start clicking. So we're gonna start 3, 2, 1. All right, we're gonna go for the next round. There's a whole bunch of people here, so I'm just gonna keep clicking. 3, 2, 1. There we go. And I think this should be the last one. 3, 2, 1. Lovely. Thank you so much, everyone, for everyone who joined us online. We hope that you learned something. If I could just have the panelists stay back. And we hope to see you in the next AMSA SRH. There's an event happening on Tuesday on postpartum care. If this is a topic that interested you and there's more you want to find out, we have an OBGYN coming in, a pelvic floor therapist coming in. We have the Birthing Kids Foundation Australia founder coming in as well. We have a perioperative nurse who's worked on these cases and have their experience to share. So please come along to that. If you can't come in person at the FMC, which is the Flinders Medical Centre down here in Adelaide, you can join us online. So please go to our link on AMSA SRH Instagram, and you can sign up for the online option. But with that, thank you so much, everyone, and we will see you at the next AMSA SRH event.
And thank you, Vienna, Dravin, and Aryan, for enabling this much needed conversation. Thank you.